I am Dr. Ntuthuko Bhengu, who will be facilitating this session. I'm the founder of Alchemy Health Technologies and an advisory board member of Consensus Health based in the USA. I'm a former National Planning Commissioner as well as a former panelist of the Health Market Inquiry, which was established by the Competition Commission to probe the private health sector to determine factors that restrict, prevent, or distort competition. I would now like to welcome our esteemed panelists, Drs. Nicholas Crisp, Paul Davies, and Ntuthuko Bhengu. Each panelist will deliver an 8 to 10 minute presentation, followed by a Q&A for the rest of the session. First on the virtual floor will be Dr. Nicholas Crisp, who is currently the Deputy Director General, National Health Insurance. He is a qualified medical doctor and public health specialist who has for many years focused on health management consulting across Africa. He was head of the Department of Health and Welfare in Northern Province and led the establishment of the National Health Laboratory Service, the transfer of medical legal mortuaries from police to health, the creation of the Forensic Pathology Services, and the establishment of the South African Health Products Regulatory Authority. Lately, we are more likely to hear and see him give information on COVID and COVID vaccination program. Over to you then, Dr. Crisp. I will introduce panelists just before they take the floor. Thank you very much.
Thank you very much, Dr. Bhengu, and good afternoon to my fellow panelists and to everybody who's watching. Thanks very much also to the organizers for inviting me to be part of this discussion. So I wanted in my opening comments just make a statement that I believe that biotech needs to have a coherent health system to thrive. And if it's going to make a meaningful contribution to the improvement of health status, it needs to fit within a system that allows it to do so. And I believe that our health system is in a, let me call it a mess. I believe it is complex, it is expensive, it has poor outcomes, which I think we can easily justify and explain. And compared with our input of what we put into our health services, we really don't get value for money or a very good return on investment. Part of the problem is that the current design of our health system, the institutional arrangements of the way we deliver healthcare in our country, is very duplicative, it's inequitable, and it really doesn't respond to the needs of the country. There are parts of it that respond very well to the demands of a small groups of people, but for the country as a whole, we really don't have a system that responds well to the country's needs, and therefore that's why we have poor outcomes. And I think that what my thesis would say is that we need massive and sustained reform if we are really going to get value for money out of our health system, and if we're going to really be able to benefit from the biotech advances that are possible and that we should be pursuing in our country. And that sustained reform has got to focus on equity. It's got to focus on solidarity, where every single person matters as much as the next person. It's got to be universal, and not two universes, one universe, where we are all only cared for because, and only receive healthcare because we need it, and not because of something else, of the geography of where we live or the amount of money we have or some other reason for providing healthcare to us. So as you've said, my job now, my recent job is I've been appointed to work on the National Health Insurance. And what National Health Insurance aims to do is to steer this reform. Now, National Health Insurance, as everybody is well aware, is not a panacea. It's not a flash in the pan or something that will happen next year. National Health Insurance is a financing system that will change the way that we purchase healthcare in our country and that we pay for healthcare in our country. And in the process of changing that purchasing arrangement, the National Health Insurance will slowly but surely change the structures and the institutions by which we deliver healthcare in the country. The basic premise of the insurance itself is that it's a single purchaser model. And what that means is that primarily the bulk of the healthcare that we as people living in this country will get will be paid for out of a single fund where we collectively pool the resources that are required to deliver healthcare. Now, we spend 8.5% of our GDP on healthcare, but we have very complicated divisions of the way that money is allocated and spent. About half of it is spent in the public sector, and it is provided through 10 different budgets, which are loosely amalgamated and called the National Health Budget, but it's nothing of the sort. It is 10 completely separate budgets that are allocated through provincial equitable shares and a range of conditional grants that are allocated to provincial administrations, either directly or indirectly for purchasing specific things. So it's a mishmash of very complicated financing in the public sector. In the private sector, we have 74 medical aids. It may be even a different number because one loses track from day to day. And those many medical schemes each have different packages, which have different risk pools, different benefits, different structures, and quite a sophisticated and complicated administration to try and track who has insured themselves for what and who's qualified to receive what. So the idea is to systematically move away from this very complicated financing system to what is called the single purchaser model. That's not to say, and the bill is very clear that it says that whatever the fund is not going to cover, that can be paid for by other financing mechanisms, other medical schemes, for instance. And so technically speaking, you never have only one single purchaser, but it's a single purchaser model. The second basic tenet of the National Health Insurance is that it will be a purchaser-provider split. And the purchaser-provider split for the public sector means that the public sector will no longer be the purchaser and the provider of healthcare, which is the current arrangement, where the referee is the player and the referee and everything else all in between. The idea is that the fund will be the purchaser and the provincial administrations will be the delegated providers of services for the public sector, and that the private sector, all the providers, will be independent providers, but everybody, both public and private providers, must be accredited by the fund in order to have benefits that they deliver paid for by the fund. So there's no intention of eroding or undermining the capacity and capabilities of the private sector, just to make that capacity more broadly available, that we get better equity in the delivery of our healthcare. The last thing that I want to say in this introduction is that in order to deliver all this healthcare, we need to have medicines, devices, technology of various descriptions to be able to do so. And the starting point, and described in the National Health Insurance Bill, is to have one formulary for that which the fund is going to purchase. Obviously, things the fund is not going to purchase needn't be in the formulary, but for those things that the fund is going to purchase by way of benefits, everything that is required to deliver those benefits, whether it is a medicine or a device of some description, needs to be described clearly, identified, available in the country, and priced. And then the fund will pay those prices, and the purchaser of the provider of the services, whether they're private or public, will be then able to go and purchase those goods from whoever is a registered supplier in the country, and they will know what prices they are going to pay for them. They will just have to show that they're accredited providers. So systematically, we need to tighten up on what it is that we are buying, what it is that we are using by way of goods to deliver the services that we are providing. And we must use health technology assessment very constructively and routinely to make sure that we are getting the most suitable products. And I use the word products in the way in which it's used in the Medicines Act very broadly. Those products must be part of the formulary, and we must make sure they're available. So I think that really that's all I want to say by way of introduction. The health system cannot be sustained the way it's going now. It's on implosion mode, and that applies to both the public and the private sector. and we need to radically rethink and reform what we are doing if we are going to look after all the people of this country going forward. Thank you.
Thank you very much, Dr. Crisp. That was very well expressed and concisely so. We will now move on to Dr. Paul Davies, who practiced as a general practitioner in Johannesburg and later founded the Medical Rescue International, which is the first private air ambulance and paramedic-based emergency medical service in South Africa. He was a member and later president of the Non-Racial Association of Medical Student Associations of South Africa, AMSA, which promoted conduct and common interests and activities between medical students of all medical schools in South Africa. Welcome, Dr. Davies. The virtual floor is yours. Thank you.
Ntuthuko, are you able to put those slides up that I sent?
Oh, okay. I wasn't aware that you actually hadn't sent through. Let me see if I can. Will you be?
Well, let me start while you find
please start.
The first slide. Firstly, I would like to thank the organizers for inviting me and for you to chair this meeting, and greetings to my fellow panelists. It's a delight to see you on the screen. Thank you very much. The first slide that I had was related to that innovation in health certainly is strangled by ideology. And that is, I think, the most important thing that I can say is that innovation is almost impossible in very fixed and confining ideologies. And the example two examples I'd like to use is that the first is you can't think out of the box if you're not allowed out of the box. And the second is that there was a mythical innkeeper thank you. There was a mythical innkeeper that existed in ancient times. And when you came to stay at his inn and you spent the night, he only had one size bed. And when you climbed into that bed, if you were too short, he stretched you to make you fit. And if you were too long, he cut off your feet until such time as you fitted into that bed. And in a way, ideologies do that to innovation. They demand some form of conformity, and that's anti-innovation. From the perspective of South African healthcare, and I agree with Nicholas absolutely, our budget, such as it is, if you combine the private and the public budgets, and even if you only just deal with the public budget, it is an adequate budget for healthcare. And you can deliver quality healthcare. And the most important concept in that is I'm sorry. The most important concept of that is to deal with what is needed and not what is wanted. And there were two very different things in healthcare. One of the big changes in healthcare now is that in the private sector, profitability was the driving issue, and supposedly in the public sector, accountability was the driving issue. But nowadays, I believe that the driving issue is efficiency, is that healthcare needs to be efficiently delivered if it's going to have anything like the potential to deal with the health needs of entire populations. Universal healthcare does not mean a homogeneous healthcare system. And much as Nicholas described, although I've not seen the detail of what he spoke about, is that universal healthcare isn't one kind of healthcare. There are really good models of integrated, hybrid, and shared models that can be used. And this is very much more important nowadays because healthcare as delivered by many governments has been sort of commoditized. And yet some of the initiatives in healthcare is to personalize healthcare as to what does each individual actually require in terms of their genetic structures, perhaps their chemical makeup, where they live, etc. So there's a conflict between commoditization and personalization in that is going to come down the track. The next item I'd like to talk about, which I think has been a very neglected component of healthcare in South Africa, if I could have the next slide, please, is that there's a huge issue, and it's an ideological one between the private and the public, and people, and I've been involved in, and I'm going to give you some examples of what I would call true public-private partnerships. The first is the definition within the word partnership. Partnership is a partnership. It is not a vendor-purchaser relationship, which is often how PPPs function in South Africa. And the most important component of that, there's no direct exchange of cash, and it's a combination of kind, where each organization, whether it's the private sector, the public sector, the faith-based sectors, all contribute in kind with a single goal in order to deliver whatever that particular structure is going to be used for. And that is really most important. If you don't have that, it's almost impossible to have a proper public-private partnership, particularly in South Africa. And the last slide, if I may, and I'm going to just dwell a little bit on these things, is that the important to make any public-private partnership work where there is a private sector and a public sector component, it requires some form of catalyst that is able to interact in that space between what are often competing organizations. And these catalysts enable and are able to fuse and integrate often very different positions. And they can be NGOs, CSOs, foundations and international organizations, etc., all of which form part of the sort of catalyzing the ability for the state and the private or public and the private sector to act in unison towards a directed and single goal. And two examples that I'd like to illustrate that I was involved in developing. The first was a cataract campaign directed by the Bureau for the Prevention of Blindness some years ago. And the problematic question is that was an NGO that derived its funding from donations and from other foundations in Germany and elsewhere, and also philanthropy. And it ran an excellent service that we structured to do cataract surgery to supplement what the state was doing. And if I just may use an example, is that at that time, there were about more than 250,000 people in South Africa that were unnecessarily blind due to cataracts. And cataracts, as you know, increase with age and other disorders. And so there's always more cataracts pouring into the bucket. And in South Africa, the ability to deal with these, I think the requirement was at that time to do 80,000 cataract surgeries a year. The state at that time was doing about 24 or 25,000. And what we were able to do was to do an additional 8,000 cataracts, between 5,000 and 8,000 cataracts a year during the life of that campaign. And this was done by integrating the ability of the Bureau to utilize public health services, the university's ophthalmology departments, nurses who voluntarily gave their time, and eye clinics were set up in public hospitals where the team would arrive. I'm sorry, I'm just being disturbed. The team would arrive at the hospital, which was the university's ophthalmology department. The microscopy and other surgical equipment was provided by the Bureau. There were some nurses provided by the Bureau and some nurses provided by the public sector. And the cost of doing that, certainly to the Bureau, we were able to purchase, for example, cataracts at about $1 a cataract from a supplier in India. But cataracts were done in those circumstances at a cost of about 800 Rand per cataract, as far as our organization was concerned. The donation from the state was factored into whatever their budgets, their existing budgets were, and the university used cataract surgery as a training venue for student ophthalmologists to participate. And as I say, that this cost the state no more than it was currently budgeting for, and we were able to increase the number of cataracts done in the country by about 8,000 per year. Just as for your interest, is that at Groote Schuur, Professor Murray told me that any cataract operation done at Groote Schuur would cost at that time about 36,000 Rand per cataract. The second one I'd like to talk about was Medical Rescue International, is that as the transition between the old regime and our democratic, the government went, the old government cut down immensely on the provision of the public provision of healthcare. Particularly, it was felt in the ambulance sector, where public health or ambulance commitments were reduced, and the ones that were reduced were the advanced capability, the advanced medical rescue type of thing, where you required a high level of care. And at the time, it cost as much to run an entire ambulance service as it did in Gauteng to run 8 paramedic high-level care ambulances. And so the first things that were cut were in their budget cuts were the high-level emergency services. I managed at the time, and tried to persuade other organizations, but I managed to interest, for example, IGI to support an advanced medical rescue system, including a helicopter, ground vehicles, and some trained paramedics. And we were able to integrate what they were prepared to give medical rescue with the state system, so that there was a unitary system that responded to emergencies within Gauteng and later throughout the whole country, all of which, from the perspective of medical rescue, was financed by IGI at the time. And the state continued with its own. They had a helicopter called Flight for Life and ground ambulance services, but both services were integrated to run as a single service. And no, there was no cash transfer between medical rescue's component and the states. The only crossover was there were some staff that belonged to medical rescue and some staff that belonged to the hospital, and some of the consumables were provided by the state. In that particular system, 90% of the helicopter and ground-based call-outs were into the public sector, and about 5 to 10%, I suppose, in the private sector. And these are just 2 examples of where I think we are not paying enough attention to just how can, and certainly demonstrated to me, that there are real possibilities of the private sector and the state working together. And I'm not talking about how this is going to be paid for, but as a system where there are certain medical delivery systems and requirements that should not be competitive between the private sector and the public sector. And for example, transplant surgery, I really don't believe should be between one or the other. It's a needed thing, and that one should structure what I would call quaternary services, where these things are set up to do transplants, and whether you come from the public sector or the private sector, you get, the costs are exactly the same, and you get the best possible care that you can have. So my own feeling is that there's been a huge amount of stifling of innovation in healthcare, and continuation of old and boring practices of how medical care can be delivered. And I think that a venue like this is an ideal starting point to start rethinking how healthcare can be delivered around efficiency and not around the old divisions of profitability and accountability. Thank you so much. Thank you for the opportunity.
Thank you very much, Dr. Davis. This is well covered, also just on time. What we will have right now, we will move on to Dr. Ntuthuko Bhengu, who is currently the Managing Director of the Board of Healthcare Funders of Southern Africa. He has served as a medical advisor and clinical executive for Metropolitan Health, was a general manager and then managing director of Aid for AIDS at MedScheme before becoming executive head of operations and clinical services at Sizwe Medical Scheme. Dr. Bhengu is recognized for his vast knowledge in healthcare management and business leadership, which has been gained over more than 20 years in both the public and private health sectors. Over to you, Dr. Bhengu. I see you have loaded your slides on your site. Thank you.
Thank you very much, Dr. Bhengu. And I also want to thank BioAfrica for inviting me. I always look forward to this conference. My particular stream of interest is that on cannabis. I find it invigorating. Let me first thank my fellow panelists. I think they have shared quite a bit of what I wanted to talk about. I'm going to focus on three areas, largely on experiences, what NHI is and what it shouldn't be about. Dr. Crisp has fortunately covered a lot of the conversation on the why, but many discussions around healthcare reform are driven by the global and even local inequalities. We know that often a person's fate is determined by where they are born, and that is not correct. When you look at low and middle income countries, we share very poor health outcomes when compared to other nations. And that covers why there is a need for healthcare reform. Dr. Crisp also rightfully mentioned that healthcare reform is not an overnight deal. It does pay homage to the adage that Rome was not built in a day aptly. If you look at one of the oldest systems, the NHS in the UK, the seeds were planted as early as 1909 with the passage of a law called the Poor Law. And over time, I think a significant time was around 1912, and then eventually in 1948, when it was implemented. Our own discussions in South Africa could probably be pointed first to the Freedom Charter in 1955, and then we had various policy documents, starting with the Green Paper in 2011, and the White Paper 2015, and now the bill. So it's not going to be an overnight thing, and we are in for a long haul. And there are going to be a lot of missed deadlines. If you look at the processes within the United Nations and World Health Organizations, we first had the Alma Ata Declaration around 1978, which pronounced that all nations must have preventative healthcare systems by 2000. That did not quite happen. We had the Millennium Development Goals 2015. We had to adjust that to the Sustainable Development Goals and UHC by 2030. So we are bound to miss some of the deadlines, but the main thing is that we are actively working towards that. What about COVID? I mean, there are many lessons, and these are recent lessons and present lessons. We have learned through COVID, and I'm happy Dr. Davis spent a lot of time talking about partnerships. We saw partnership in action with the private sector and the state working hand in hand to solve some of the issues. We realize that finance is very important, and when you pool resources, you need not only look at one area, you need to look at all the available resources. Some of these lessons haven't been pretty, but you also have to remember the painful lessons. And these are around the governance issues. We have seen painful elements of PPE purchases, and more recently, the scandal around communications in the Department of Health. Now, all these are important for us when we craft the path ahead towards NHI. It's not about the law. We spend a lot of time criticizing and only considering what's in the bill and not saying what is it trying to solve. Dr. Chris has talked about the stark realities. We can talk ad nauseum about the poor health outcomes, etc. But that is what this is about. When you talk to the person on the street, that's what they worry about. They worry about the waiting times. They worry about the crumbling infrastructure. They worry about poor outcomes. They worry about few healthcare professionals that attend to them when they are in time of need. In addition to that, we cannot hope to be successful in implementing a good health system if we do not pay attention to other social determinants. When you look at the Sustainable Development Goals, it addresses a whole host of areas, dealing with poverty, overcrowding, gender equity, water and sanitation. If you speak to somebody in the Val, they'll be more concerned about the stench of raw sewer that is in their streets than elements that are captured in the bill. And you can also not be confident in dealing with these challenges, health challenges, if you don't deal with these social developments. Unfortunately, the how in terms of implementation is mostly about the law. So we have to pay specific attention as to how the various elements in the bill are captured. We have to look at the constitutionality of the bill. There has been a number of issues. When you implement a process or a project, you make sure that it is still in line. Does it take anything away from the rights of the person? The caregivers, are they sufficiently catered for? Some interpretation of the bill points to exclusion of service providers who might not be part of the bill. Dr. Chris talked about the single payer model. If you have a single payer model and you have nothing outside that, our practitioners who do not qualify to participate in the NHI structures, not having their rights infringed. And those are some of the things that we need to look at. The NHI bill, is it fit for purpose? Does it contravene the structures operationally? Is it fit for purpose? And those are the discussions that we are currently having, even at the parliamentary portfolio committee level. The other thing is that it's more than a bill. Often when we talk about NHI, people will think that once it's implemented, it solves all the problems. It's not a silver bullet. While we have the bill, it covers a specific area that we've spoken about, whether you're talking about the benefits that are defined there, the pricing, the fund itself, how it's structured. But outside that, you still have elements that are only captured in the Constitution or in the National Health Act. And you still have the privately funded schemes that are also going through their own reform. You've got the Medical Schemes Act. You also have elements or other bills that are in the pipeline, like the Conduct of Financial Institutions bill, the coffee bill, which will have a very big impact on how healthcare is delivered, because these institutions, and arguably even the NHI fund, can very well be described as a financial institution. So it's important that we look at everything in total. We had a commission that ran for a number of years. Dr. Bhengu, you were a commissioner on the health market inquiry. It had very good and sound recommendations of healthcare reform. While we implement the NHI bill, we must not forget those important elements. And lastly, in this, governance is important. I mentioned just now around the painful lessons. When we look at the bill, we must make sure that it is structured in a way that it will work. And I think sometimes we make the mistake of writing a bill based on the personalities that are currently in charge. And when you then have somebody else coming in when you've given them a lot of power, we then end up in a state of bother because we did not plan for the worst case scenario. We have to make sure that we put the right governance structures, twin peak or even triple peak assurance method of oversight to make sure that there are checks and balances, to make sure that we don't see the same challenges that we face now with COVID. Let me stop there, Dr. Bhengu, and then we can discuss some of the other elements through the Q&A. Thank you.
Thank you very much, colleagues. It's amazing how all three of you met the 10-minute guideline. Thank you for that. We will then just go back to we're now going on to the Q&A part of the discussions, and to just kick this off, I will pose the first question to Dr. Chris, and that really will be, does South Africa really need to reform our health system? One hears from time to time, people say, look, healthcare is already available to anyone, who, even those who can't afford it, based on the means test. So what's new? Dr. Chris, would you like to respond to that question? Does South Africa really need to reform our health system?
Sure, thanks very much. Well, the truth of the matter is healthcare is not available to anyone when you need it. Healthcare is available to people who have money, you need it, and even when you don't need it. And you get lots of healthcare, even if, but for many people who suffer with cancer, who have disabilities, who are, we heard earlier, people with cataracts, technically they have access to it. But in practice, they don't have access to it because of the structure of our systems. And if we were able to use all our specialists, all our general practitioners, all our services to serve everybody, then the chances are far better that we would be able to get everybody to have better access to healthcare. So that's one of what the NHI is planning to do. The aim is to have strategic purchasing. And Dr. Davies spoke about innovative and flexible methods. That's exactly what you want. You want a service delivery platform that responds to the geography of the area, to the epidemiology of the area, and to the capabilities of the team, that people are allowed and encouraged to work in teams, and that the fund can then purchase from the people in that team. And if there is no possibility of providing care in a team near to the place of residence of the person who needs that particular care, there must be an obligatory referral system properly designed that makes sure that that person can go to where they need to get that care. We spoke briefly about transplants earlier. I think Dr. Davies mentioned that. Why would we only allow people who live around tertiary health services to get transplants? I mean, even kidney transplants, which are relatively common these days, are limited to people who pretty much live within striking distance of big tertiary hospitals and big private hospitals. That doesn't mean we don't have people who would benefit enormously from a very good life if they were able to have proper renal care. So I believe that we think, because we live perhaps in the first world, and because we see a system that is theoretically designed that allows anybody to get to a public health institution, that we have now created universal access. It's a fallacy. It's a universal access if you live on the doorstep of Grootskeer, Tygerberg, or Steve Biko Hospital. It's not universal access if you live where I spent my clinical years, in deep rural Venda and Gazankulu. It's just not accessible to those people. But there are people who deliver really good healthcare, who were in the same classes as the rest of us at medical school, the same nursing institutions as the nurses who work in the public sector, who are quite capable of delivering that same care to the same patient, if only we could find a way to pay for it. And that's why we want a different financing system. Thank you.
Thank you very much, Dr. Crisp. please don't switch off. There is one that I just want you to follow up on from the chat room. I think there are two questions here. I think you've largely covered the first one. I think the one here is really about practical steps. How do you envision the practical steps in reforming? I think we get the big picture as to where we want to get, but I read this question as basically asking, okay, what's next?
Okay, brilliant. So it's unfortunately a very long explanation. I'll try and keep it short. But Dr. Mthudi got it hit the nail on the head. It's a process. It's not an event. You will not suddenly wake up on the 1st of April next year in the new financial year and the national health insurance is there. The same will not happen in September. The same will not happen in December. Steps need to be put in place and things need to be changed slowly so that you don't break the entire system. You learn as you go and you work within your means. But you need to move in a direction. And that's what the bill tries to do, to create the enabling environment. So the first step is to create the capability of doing the essence, the foundations of the system. So we are creating an office. It will start off in the National Department of Health because we don't have an entity to put it anywhere else for now. And we will start with a relatively small group of people in permanent positions who are able to do the next level of design. So that is not the theory and the history and the research, but the actual nuts and bolts of what does this clause in the bill actually translate to in terms of a regulation and a standard operating procedure and a form that somebody can actually see what it looks like. So what is a health benefit? How do you describe it? What are the elements of the benefit? What's included and excluded in that benefit? How does it get coded? How would it translate into the GP's daily task of seeing a patient and recording, I've seen a patient with X, same with the hospital procedure and so forth. So those are the kinds of nuts and bolts. The second thing that needs to happen is that we need to systematically start to understand what will the impact be on the provincial budgets when we shift primary healthcare payments to the fund and not through the provincial equitable share. Money. Who's going to pay for what, when, and how do we know where to distribute that money to if we're changing the system? So you need to run a parallel offline estimation of how you're going to spend the money and compare it with the actual allocations of the money as we go. And to do that, we need to work with the Intergovernmental Department of Treasury. We need to work with the Finance and Fiscal Commission, who we've already been working with on formula allocations. We need because we're going to work on capitation for primary healthcare, we need to look at what is the structure of that capitation formula? How does it differ from how the FFC and the current Treasury formulae work? And so forth. So there are many building blocks, and you do it slowly but surely. When we get to hospital care, what is the structure of a DRG? Which one of the big DRGs are we going to follow in the country? How do we switch from fee-for-service to DRGs? Some medical schemes have already experimented with this. What have we learned already, and what are the processes going to be? And so on, and so on, and so on.
Thank you.
So Dr. Mthudi got it right. You do it systematically, sequentially, and carefully so that you don't break the whole system as you go. Thank you.
And if I were to hear you say the next step is to establish the NHI office with permanently appointed people to start that process of considered step-by-step transformation towards the end goal. I've got a question for Dr. Mthudi now. How can the policymakers future-proof the bills instituted today with the future in mind? Would you like me to repeat that, Dr. Mthudi? How can the policymakers future-proof the bills instituted today with the future in mind? This question is also in the chat box.
No, thank you very much, Dr. Bhengu. I think the important thing is that we have vast resources, And the issue of collaboration is key, even at the policy level. Sometimes when you have a narrow view of the environment without involving all the stakeholders, you may miss some of these elements. We also have to make sure that as far as possible, when we deal with issues of law, we make sure that while there might be some political motivation to whatever project we implement, we make sure that we stick to the right tenets of the law. And my short answer would be consultation far and wide. We have a very good system in South Africa in terms of how bills are enacted. Lots of consultation. We have to make sure that we use this process not as a tick box exercise. Make sure that the contributions that are made, input given by the various stakeholders are actually researched, and make sure that they fit or fill in some of the missing blanks that could have escaped whoever was a proposer. And I think in that way, with the wider participation, good research, you may be able to avoid some of these potholes. Thank you.
Thank you. Thank you very much, Dr. Mthudi. I will pose the next question to Dr. Paul Davis. Having obviously listened to the two examples he gave us about how far progress was made on both the cataracts and Medical Rescue International, where do you think the problem is? Okay, maybe the question is, do you think, Dr. Davis, that right now we do have the capacity to achieve this much? The examples you gave in 2021 and 2022, if not, what do you think are the obstacles to us achieving this? If yes, are there any other examples other than the transplant example you gave us where you think are low-hanging fruit, where this can be looked at by Dr. Chris and his colleagues? You're on mute, Doc.
Yeah.
Okay.
Thank you very much for that. And I'd like to thank the panelists for raising a lot of the important issues around this. Is that I absolutely believe that it's possible to run combined or integrated public-private delivery systems, but you have to choose them carefully. And I'd done quite a lot of work on this some years ago. But for example, respiratory ICU is the criteria for these are to find delivery requirements that require a high level of expertise. They're usually expensive, and they usually have quite expensive material and technology surrounding them. But the important thing is that the amount of patients who genuinely required those, in a sense, were few. And for example, transplant for sure fits into that category. And for example, I'm associated with the Donald Gordon, and they do quite a lot of the liver and kidney transplants, whereas the GEN's ability, the Charlotte Motsechi Hospital ability to do transport, to be transplanted is minimal. But I can tell you now that that particular unit is dealing with mostly all the transplant units, the transplants that are occurring in the public sector. And all that, the requirement is to pay the fee. And yet there is a huge amount of, I don't know, ideological bad blood between the public sector and the private sector in this space. And it's an unnecessary thing. The emergency services are still an area that would do exactly, and I'm talking of advanced or high-level emergency care. You know, that can be easily extended from where it exists now around the main centers into other areas. And what's the important thing about that is that you can select which hospitals patients should be referred to. And the initial proposal for a high-level delivery system was to not keep creating more advanced hospitals, but to be able to take people living far away from those hospitals to them in safety. And that possibility is there, but it's not much used because people say, well, it's expensive or it's not organized. And cataract still exists as a huge problem in this country, and it's one that could be tackled quite easily. And I think that if you sat down carefully and looked at what I would call quaternary health requirements, which don't have to be competitive between the private and the public sector, you could start working on those very, very quickly. And what was interesting for me is that one could have these systems within existing hospitals. They didn't have to be created as separate entities, but just were accounted for in a different way to the other. But what is important is that access to them, whether you come from the private or public sector, is the same. The cost is the same. The requirements are the same. And you can build those steps in quite quickly. Well, you won't have to wait for these very high level processes to take place before you create the actual delivery capacity into a system that can easily take it on now. It just requires flexibility. And as I said, it requires a shift of ideology or a reduction of ideology. And I find that working as I do as a director at the Donald Gordon is that there's a huge antipathy between the private and the public sector. And it's an unnecessary antipathy. Everybody wants to achieve the same ends, and there's a lot of willingness as well, but an incapacity to know how do you, and that's why I referred to that catalytic requirement. And whether it's, for example, PEPFAR has poured in a huge sums of money into the management of HIV in this and other countries. And it's done so without taking or giving any money. It's just set up systems that work within mostly the public sector, but also the private sector. And it is the catalyst that allows for the development of capacity within our health system that perhaps wasn't there before. I just think that one has to just put a different thinking cap on. And try and work out, instead of sticking to structures and bits of paper, is to say, well, look, how can we efficiently take 10 items that absolutely need to be delivered that aren't being delivered well now, and say, well, how do we solve those? So I would do it in a different way. I wouldn't start at the top. I'd start with how do we deal with what do we need to deliver and how best can we design that to work properly.
Yes. Thank you. We've got 5 minutes before.
Sorry, Doctor.
No, that's fine. The point I want to highlight is that all three of you, of course, definitely come around to the need to collaborate, even though you're starting off from different perspectives. I want to just follow up on your point here that there is a significant antipathy between public and private sector, at least in the space where you operate. And Dr. Mthudi earlier highlighted that through COVID, there are many lessons that we are seeing. Among the positives, of course, is the collaboration, a point that Dr. Crisp also made. But I want you to wrap it up looking at the point in the checkbox that Dr. Crisp makes as well, that working together is not so difficult. Issues seem to be about payment for these shared services. Now, where you say there's antipathy between public and private sector, is payment one of the reasons that's the case? Please, if you just respond very briefly on that one, because I want to take it a bit broader and ask for Dr. Mthudi, given that he's in the funding sector, to say, how can this be tackled if it remains a problem? Is payment, Dr. Davis, one of the problems that drive the antipathy you see?
I think payment is a problem, but it can be, certainly in the transplant space, it can be easily changed in the sense that a lot of the laboratory services that are required for transplant could be done by state laboratories. And the cost of that would have been able to reduce whatever the province owes. What has happened is that there's a collapse in transplants at the Charlotte Matete Hospital, and that's not a good thing either.
Yes.
But so payment is very important, but I can tell you that it's scarce skills that are perhaps more important. Is that the level of and there are a few transplant surgeons in the country. They're not queues of them, and so the university should be training them,
Yes.
and that would compensate also for patients coming from the state if you could factor in the cost of training a surgeon and mitigate that against the cost that the state would have to pay for a transplant. I just think there are many interesting ways that you can look at this problem.
Okay, thank you very much. I will give a minute or less each. First, Dr. Ntuthuko, just do you have any quick, brief ideas on how the payment issue can be gotten around? And we'll close with Dr. Chris just highlighting the lessons from COVID of how we're dealing with the payment systems. Over to you, Dr. Ntuthuko.
Thank you, Dr. Bhengu. Let me summarize by saying that there are some central themes when you look at health reform. One of them is around contracting for value. And I'm glad that Dr. Chris spoke about the alternative reinvestment models that are already operational in the private sector, including DRGs, for example. I think the issue of payments now is big because it's been neglected for so long. If you think about collective bargaining, if I can call it that, not being possible in the private sector since around 2005 or so, and the issue of the tariff files halted around 2009. I'm saying it's a challenge because it has been neglected for so long. But while we are attempting to correct that, we must look at the issue of contracting for value, because that will take the focus away from the problems around fee-for-service inefficiencies, etc. And just to round up, the other elements, as I said, around health reform, focus on the customer, making sure that we focus on those elements that provide for good outcomes for the clients. Thank you.
Thank you very much, Dr. Chris. Short, sharp bullet points, what have we learned? Dr. Chris, are you online? Okay, for whatever reason, we don't seem to have him, but we're out of time anyway. Thank you very much, colleagues. This has been extremely helpful and engaging sort of discussion. Dr. Chris, you seem to be back. Do you want to take? Yes, please.
I'm here. Can you hear me?
Yes.
Thanks very much. So yeah, I just I missed a bit because Zoom updated while I was busy. So I just wanted to say that I do believe that there's lots of room for innovation. There's lots of room for working together. During COVID, we've had a lot of collaboration between public and private sector on things that would have never happened in the past, including on agreements on various prices and so forth. And I think that setting aside differences from the past and working together is the only way we're going to fix the health service going forward. Thank you.
Thank you very much, colleagues. That's the end of this session. Thanks a lot. We over now. Bye.